Hi guys, welcome back to For Strong and Growing. My name is Alexa and I'm 38 weeks pregnant with my third baby right now. She's due on Thanksgiving, which is in just over 2 weeks. She's going to be making her appearance any day now. Since getting into my third trimester, I've been thinking more about my birth plan. I didn't have a birth plan with my first baby. With my second baby, I decided to write a little birth plan, and I went back and revisited that birth plan, and I decided that I wanted to make quite a lot of changes to it. I've been doing a lot more research and I found out a couple things that are actually pretty alarming that I feel like are not common knowledge. So I thought it would be interesting to make a video and to kind of shine light on those things that I've learned, just go over what my new goals are for this birth, and just talk about birth and birth plans. So if that's something that you're interested in knowing about, just keep on watching. So I'm going to put my old birth plan up on the screen right here, and let's just start by going through what I had written in this old birth plan. I wrote this 4 years ago. At the top, I start off with basically a disclaimer being like, hi, I'm not going to be a difficult patient. I promise. I understand that sometimes you have to do your thing, even though I want it done a certain way. You're going to have to do it a different way, and that's totally okay. And you're the professional. These are just preferences of mine. I didn't even write birth plan. I wrote birth preferences because I wanted them to know that I'm not going to be difficult, and I know that things don't go to plan, and yada yada yada. I ended up taking out this disclaimer because I just feel like it's too much to read. I don't need these people reading an essay because that in itself is difficult. They will realize that I'm not difficult and that I'm willing to work with them. I don't need to write it down on the paper. Next, I wrote down in the labor section who my primary support person is, which is my husband, obviously. Again, I feel like that's not really information that they need to know. He's going to be the one there with me. It's going to be pretty obvious that he is my primary support person. Then I wrote that I would like to use water therapy or a tub. Unfortunately, at the last hospital that I went to, they were in the middle of renovating their new labor and delivery suites. So I was stuck in this other part of the hospital and there were no tubs to labor in, which was so sad. And I just missed the brand new renovated labor and delivery suites, but that's okay. So this didn't end up coming in handy. But again, I did not add this to my new birth plan because I just feel like it doesn't need to be written on the birth plan. I can just go there and ask to use the tub. So next we have the delivery section. I wrote I would not like to touch the head as it crowns. I feel like they use this as a way to motivate you, and they'll say, oh, I see the head, or like, oh, she has hair, like, do you want to touch? And I am just completely grossed out by that. I will never reach around and touch. I'm also not the type of person to watch in the mirror. I know some people like roll in the mirror and they want to watch and it like motivates them. I cannot. I do not want to know what's going on down there. Not that I could probably even focus because I've never used an epidural before. So like I'm on a different planet anyway. I don't think I'd even be able to focus. But even if I could focus, I would not want to watch that. And I don't want to feel that. So even though this is still true, I didn't write it on my updated birth plan because if they ask, I'll just say no. And it's as easy as that. I wrote that we want delayed cord clamping for 1 to 2 minutes. That is the same. That is still on my birth plan. And I wrote that we want the medical personnel to cut the umbilical cord. I don't know if that's still the same. I actually didn't ask Matt if he wants to cut it this time or not, but that's something, again, that doesn't really need to be written down on the plan, in my opinion. We can just kind of figure that out in the moment. Who knows how he'll feel? Imagine if I wrote it down on the paper that he doesn't want to do it, but then in the moment he felt like this urge to do it. I just don't want to make it more confusing than it needs to be, so he can make that decision in the moment. After delivery, I wrote that we don't want our baby to be circumcised, and obviously that does not apply this time because this baby is a girl. But if I was having a boy, that would be staying on my birth plan. So overall, I just felt like my old birth plan had a lot of unnecessary information on it, information that we could just easily express to the medical personnel when we were there. So that's one reason why I was changing a lot of this birth plan. And another reason is that I've been looking a lot more into birth injuries, and I'm more open-minded to the idea of an epidural. So I started looking into different sorts of pain management, and I found out some interesting things that I didn't know. So now I'll put up my updated birth plan on the screen here, and we can just start going through that. So at the top, I wrote birth plan, not preference, and my name. It starts off with, please note that and then I have a medical condition. I just blocked it out because I don't really want to put that on the internet, but it's just, please note that I have this medical condition condition. If I was GBS positive, then I would also write that there, but I'm GBS negative this time. Then I have that my delivery preference is vaginal. And then, like I said, I've been looking into birth injuries, and I've noticed that a lot of birth injuries come from the use of external medical instruments that are used to kind of help the baby out of the birth canal. So that's like vacuum extractor and obstetrical forceps. So I don't want either of those used. Sometimes if the mother is having a hard time pushing, if she's been pushing for hours and hours and hours and has exhausted herself, the medical team will suggest using something like a vacuum extractor pump or forceps to help grab onto the baby's head and pull them out of the birth canal. But as you can probably imagine, pulling on a very delicate baby's head and neck can cause a lot of damage. Not only can it cause damage to baby, but it can also cause damage to mom. I'll put up a picture of what a vacuum extractor looks like. It's basically this like soft, I think it's like a silicone suction that goes onto the top of the baby's head, and it helps to pull the baby out of the birth canal. The use of a vacuum extractor can cause damage to the baby, like bleeding under the scalp, skull fractures, brain damage, cerebral palsy, and intracranial hemorrhage. So all very scary things. And there are also some risks to the mother, like urinary incontinence, which is not as big of a deal, but still something that I would want to consider. Now I'll put up a picture of forceps. Forceps are basically a medical instrument that I believe are made out of metal. It might have something softer on the actual pincher parts that are going to touch the baby's head, but they help pull them out of the birth canal. So on the lower end of severity, according to NHS in the UK, about 1 in 10 babies get scars from the forceps. But then also some more serious things can happen, like cerebral palsy again, skull fractures, seizures, and temporary facial muscle weakness. Again, just like with the last instrument, there are risks to the mother, like urinary incontinence, bladder or urethral injury, blood clots, and uterine prolapse, which freaks me out so much. Uterine prolapse is so disgusting. That's like when your uterus basically hangs out of your body. And then rectal and vaginal tears as well. All in all, I don't want to go anywhere near these things. So on my birth plan, I wrote that I don't want either of these instruments being used to pull my baby out. The next thing that I have on my birth plan, I feel like if certain doctors read this, I might get an eye roll because it looks like I think I know everything in the world and I think I'm some doctor, but really these are just things that I've researched and this is the information that I found. I'm not going to be embarrassed of putting this on my birth plan, but it does sound a little bit over the top. It says no Hibbard maneuver for grade 1 through 3 shoulder dystocia. Dystocia means difficult birth, and a shoulder dystocia is when the shoulder of the baby kind of gets stuck behind your pelvic bone and it's preventing the baby from birthing through the birth canal. Maybe the head will come out and the shoulder kind of gets stuck. It's more common in boy babies and full-term babies because they're bigger. There are also stages of how severe the shoulder dystocia is, and then there are a handful of maneuvers that you can use for each stage to help get the baby out vaginally. Because I said I don't want this one maneuver being done, which I'll explain what it is in a minute, I did write down the other maneuvers that I am okay with them using because they don't all have a lot of risk. It's just that one maneuver that I'm uncomfortable with. So let me explain why. The Hibbard maneuver is, in basic terms, pushing the baby's head back into the birth canal in order to then rotate the baby and get them to come back out. I'm explaining that very loosely. The problem that I have with that maneuver is that there are so many complications related to using excessive force when doing this maneuver. A lot of less experienced doctors will use this one because it is easy to do, but it's also easy to mess up and use excessive force, which causes a birth injury. The injuries can cause paralysis in one of the arms and hands. It can also cause cerebral palsy, and I am just not okay with taking that risk when there are so many other techniques that can be used instead. Then I did clarify in the next line, the only time that I am okay with the baby's head being pushed back into the birth canal is if it is the worst shoulder dystocia that they can diagnose, which is a stage 4 shoulder dystocia. And that means that I need an emergency C-section. And I can't just have the head sticking out out of me during a C-section. So that's the only time that they're allowed to push the head back into the birth canal. My next bullet point has to do with pain management. So like I said, my goal for this delivery was just an unmedicated vaginal birth in a hospital, but I am not against using analgesics if I feel like I need some pain relief. First, I would probably ask for IV analgesics, but not fentanyl. And this is going to be a theme throughout the rest of the video. I do not want fentanyl. Fentanyl, in my opinion, is just too dangerous of a drug. It is not something that I'm interested in taking whatsoever. According to the DEA, fentanyl is 50 times stronger than heroin, and it is 100 times more potent than morphine. Just give me the morphine. I don't need anything as crazy as fentanyl. So on my birth plan, I have no fentanyl written multiple times. Another pain management option that I have written on here is a walking epidural without fentanyl again. Did you know that there's fentanyl in epidurals? I had absolutely no idea that that's a drug that they were putting in an epidural, and I feel like that's not common knowledge. I was under the impression that an epidural was just like a local anesthesia drug. I had no idea that they were putting opioids into their epidurals, especially because even though it's only a small amount that gets to the baby, these drugs get into the baby's system, and I do not want my newborn exposed to fentanyl. So I could probably make a whole video on epidurals. There are different types of epidurals. They each have their own benefits and risks, and each hospital might do it a little bit different. Now you might be wondering what else is in an epidural. From what I have found, an epidural is a local anesthetic, something like lidocaine or bupivacaine, plus or minus an opioid such as fentanyl or hydromorphone, or sometimes even sufentanil, which is even stronger than fentanyl. And you might be wondering, why are they putting opioids into the epidural? It's to lower the amount of local anesthetic that they use to lower the side effects of the local anesthetics. So there are a couple types of epidurals. There's just the normal epidural block that most people are used to. It is a catheter that goes in the epidural space in your back. Then there's a spinal block, which is more common for like a planned C-section. It works really fast, but it only lasts for about 2 hours. It's just a shot in your back and there's no catheter. And then there's a combined called a CSE, combined spinal epidural. So that's when they give you the spinal block first, the shot in your back that lasts about 2 hours. So it has a really quick onset and you get that pain relief really quickly, but then they also place an epidural catheter and that will maintain your pain relief over a longer period of time. So depending on the type of epidural that you get and what drugs they're actually putting into the epidural and the dosages of those drugs kind of all determines whether or not you will be able to get up and walk around, or if you will be confined to your hospital bed. And then if you're there for a few hours, you're gonna have to put a urinary catheter in. And if the drugs are so strong that you can't even feel your contractions and you can't feel yourself push when it's time to push, you don't know what area you're even feeling, you can't feel anything. And then that leads to you needing a vacuum extractor or a forceps delivery. Nope, that is not the road that I want to go down, which is why I specified that if I am to get an epidural, I want a walking epidural. And the reason why I'm writing it as a walking epidural is because I want it to be very clear to them that whatever their hospital policies are, I want to be able to walk. And I don't know what those policies are, so I can't write exactly like, I want this drug, whatever else. So I'm just writing, I want to be able to move around while I have this epidural. So my last section is dedicated to if I need a C-section. I'm gonna be honest, in my last 2 pregnancies, I never even really considered needing a C-section. That is a fault of mine. I definitely should have been more prepared. Luckily, I never ended up needing one in the past, but you never know. So now I have looked up much more information about C-sections just in case. Again, I have an epidural without fentanyl as my first bullet point because I will need an epidural if I'm getting a C-section. Then I have a surgical drape that I cannot see through. Again, I don't want to see anything that's going on. That's just going to make me feel sick. And the last bullet point for the C-section is that I would like a transverse incision. So that's a horizontal incision instead of a vertical incision. The reason that I don't want a vertical incision is because there is a much higher chance of uterine rupture in subsequent pregnancies after having the vertical incision. And I would like to have more kids, and I probably would try to have a VBAC, which is a vaginal delivery after a C-section. So a transverse incision is definitely the way to go. And then the last section is after birth. And the only thing that I have written on there for now is that I would like delayed cord clamping for 1 to 2 minutes. I will put up on the screen this screenshot. I think that it's really useful. This wonderful woman here, what's her name? Mama Nurse Tina. She went through all of the governing organizations surrounding obstetrics, and she wrote down what their recommendations are for delayed cord clamping. She references ACOG, SOGC, the European Panel of Expert Neonatologists, Consensus Guidelines, the International Liaison Committee on Resuscitation, American College of Nurse Midwives and Mothers Australia, the WHO, NICE, and ARCOG. So she wrote down all of their recommendations, which is how I came to decide between 1 and 2 minutes for delayed cord clamping. So those are all the changes that I am making to my birth plan. It's kind of a lot of changes, but I feel like they're very important changes. I also think that it's really important for the everyday woman to know what goes into an epidural. So many women get epidurals. I don't know what the percentage is, but I'm assuming it's 50% or more. And because they're so common and so many people get them, I feel like it's easier not to ask what's even in it, because most people are fine when they get an epidural. But I really want to encourage everyone to look into the different pain management options and actually know what you're putting into your body and your baby's body. So I hope this video was helpful. If you liked it, please give it a thumbs up. And if you have any more information, if I got something wrong, please leave a comment below. And I will see you in the next one. Bye.